The next presenter is Mark Gilchrist on OPAT stability studies.
Thanks very much. And thank you very much for the invitation. And it's great to be back with colleagues old and new, particularly Fakade, Steve, and Jason. So I'm going to talk to you about outpatient parenteral antibiotic therapy and the roles of what we've been doing to collaborate across the 10,000 kilometre difference that exists between us. So the demand for OPAT continues internationally. There's been over 1,000 publications on OPAT over the years since inception in 1974. But recently there's been a refocus on service redesign, novel therapeutics, efficiencies in care and how we optimize OPAT, particularly from a stewardship perspective and reducing its impact on AMR and antibiotic resistance. And why is that important? Why is OPAT important? We're still in a COVID era, we're still recovering and we're still delivering that response. There's been a decline in capacity across organizations. I think we're still feeling that. I'm feeling that in my clinical practice. Patient flow is therefore a problem because declining capacity, we can't get people out. Social care is a problem, and how do we manage that? And so we need to think about how we do things differently with a patient-centered approach, care closer to home and equitable care as well. So just because of what our preconceptions are does not necessarily mean we can't deliver care in a home setting. And that means there's a gap. There's a gap between how we treat OPAT and how we treat AMS. Infection is one of the commonest reasons why you enter hospitals. It's also one of the commonest reasons why we complicate hospital treatments and surgical interventions. And about 4% of the population now are immunosuppressed, and so therefore we are having to deal with an increased population that's got susceptible to infections, and how we treat that and how we keep going. But one of the biggest dilemmas for us, as well as the innovations on shorter durations and oral antibiotics and once-a-week antibiotics and things, is the delivery to use antibiotics in the home as an infusion, and drug stability is one of those problems that we haven't really come to really grapple with. We looked at this back in 2015, 2016, so it's almost 10 years ago, and I was reflecting on Jeff's sort of nature as we go through timelines, but that we've been looking at this for 10 years now, and we looked at the data for drug stability testing. We looked at all the articles that were published, and there was 117 of those, and we compared them at the time to what was called the yellow cover document. Yellow cover because of the colour of the actual document, it's a literal thing. But looking at testing protocols, criteria and standards. So that's about pH, it's about colour, its stability, degradation rates, reproducibility, and also the fact that is the drug that's left in the container at the end of the infusion effective for what it actually should be doing. And there's differences across the world, but the UK has a stricter protocol. And surprise, surprise, there was zero that met that of all the literature that we looked at. And since then, we've had open access. We've delivered over 5 or 6 publications of drugs, from flucloxacillin to pip/tazo to meropenem to the newer generations of anti-infectives that are now being delivered in care on the ground as a result of the work that we've been able to do. But it opens up a question about what is the safer patient pathway. So we need to be looking at the evidence, we need to be looking at PK/PD targets, avoiding toxicity, looking at the temperatures of these, because these are devices that we attach onto pouches on our body, so they're different to what we use in hospital. And are we looking at the options that we've got available and maybe unnecessarily restricting our options for use? And we need to build a global community of practice and care that's universally acceptable. And that's exactly what we've done through partnerships with the University of Queensland and the great people here, where we've tried to gain that consensus and expand the number of agents that we've tested. And I'm really pleased to say that we've moved outside of antibacterials to antivirals. So we've looked at acyclovir, we've looked at amoxicillin, temocillin, which isn't available in Australia, but is in other parts of the world, and Keftaz avibactam, which I'm not going to talk about because that's going to be spoken about bespokely towards the end of these talks. But it is important because we've been able to take patients out into the community based on the work that we've done. So that work that's been done here is now affecting care in other parts of the world, and I think it's something that you all need to be really proud of. There were international consensus guidance that sort of came out last year around prolonged beta-lactam infusions, and there was one question in there which we were involved with, which was about stability concerns. Surprise, surprise, there are no RCTs around this. The final concentration of the drug is dependent on many factors, and maybe therapeutic drug monitoring is a solution to some of the stability concerns. But again, there was a call for global consensus. And that is exactly what both of our organizations are trying to do. There is a paper that's under consideration at the moment looking at what is the consensus for stability testing, and it might help answer the questions that still our colleagues and friends in Spain have put to us, saying should there be different protocols for different drugs depending on what their degradation rates are. But does it make a difference on the ground? Just to finish, it does. It's made industry rethink what it delivers in pumps to the wider community. So industry have changed the way in which they deliver healthcare based on some of these results, and that's really important. To the patient, we have open access methodologies now. You can access them on the web. They're freely available to everyone, so organizations can make their own pumps if they want to, and again, that's a step forward. And we've also challenged the literature in peer review, so peer review criteria for publication has been rethought and is being rethought at the moment. Does it make a difference to organisations? Well, it does. And where I am in Scotland and England, they have transformed the way that healthcare is delivered. There's more money put towards it. And that more money is around drug devices as well as healthcare infrastructure. So it is making a difference on the ground. And I very much hope that partnership continues. And then just to finish on, we are collaborating and looking at wider aspects of OPAT on the ground, whether that's increase in the telemedicine approach and increase in oral agents, but also increases in equity of care, increasing in the devices that we use. Subcutaneous OPAT is a big thing. It's coming along. What are the benefits of that, and what's the literature about that? And is therapeutic drug monitoring in an OPAT setting a way that you can justify some of the stability concerns as we go forward and as TDM is more impactful in organizations around the world as well? So we look forward to that strategic and management case. And thank you to everyone on the screen and more, but particularly Jason Ficcardi and Steve for their work and ongoing collaborations. So thank you very much indeed.
Wonderful. Thank you very much. Clearly shows that indeed stability is an important thing, not only in OPAT, by the way, but definitely very relevant research.